Each manufacturer will have their own sort of certification process in order to use their design. So a lot of the certificates on the wall might be for individual sort of certifications. But as far as it is great if someone is a member of at least a contact lens, Australian Contact Lens Society. I think it's called the Cornea and Contact Lens Society of Australia now. The one that's dedicated to Ortho-K is the Orthokeratology Society of Oceania. And often being a member is enough of those. You can get additional certification and become a fellow. I have not gone through that process, but I've got 20 or 30 years of experience to sort of back myself up that I haven't gone down that path at this stage. And I know the vast majority of people in those organizations are just members, and they're all very good, experienced Ortho-K practitioners.
And like what type of diagnostic tools would an experienced Ortho-K practitioner typically have in their clinic?
In addition to the regular setup, probably the key one is that they need to have a corneal topographer, which is a particular instrument designed for getting very accurate measurements of the eye shape. So not only does it allow you to understand what challenges you might meet with a particular patient before you start with an Ortho-K lens, that helps you choose which design is going to work best. It might help you predict their suitability and success rate, but it's a vital piece of equipment for making sure that the lens is fitting well at each visit. And if you are someone who's using Ortho-K as a myopia control tool, then the increasingly strong advice is that you have some sort of way of measuring axial length, not just prescription, as a way of monitoring your success at slowing down progression in myopia, because the primary sort of parameter now that's being monitored for myopia control success is axial length. And so just over each shoulder, over this shoulder is my OCT, which does biometry, so it measures axial length, and over the other shoulder we can just see my corneal topographer there. And so they're the two probably vital bits of equipment now in modern Ortho-K practice, in addition to having trial sets. I mean, I've got a number of different trial sets so that we can move between and choose what we think is going to be a best match for a particular patient, particularly when you start getting into, do they also have astigmatism with it? Is it someone who's actually coming in who's actually long-sighted rather than short-sighted? So there are things around the edges on some people that we can do some different prescriptions to what you might have traditionally thought. But that's part of the process of identifying whether someone's a good candidate or not. That's a very much a part of the initial process is making sure that you're suitable, so that it's not a one size fits all approach.
I have actually heard of cases where people have been using like traditional RGP lenses for a while, and maybe the fitting process initially wasn't done well, which has left some sort of long-term scarring. I don't know if scarring is the right word, but in any case, it's perhaps made them not a good candidate for Ortho-K. So, are you really looking for those types of things as well before you sign somebody up for Ortho-K? Are you checking whether there are any irregularities in their cornea?
Yeah, absolutely. So, coming across a long-term rigid lens wearer is a lot rarer now. Someone who's wearing a rigid lens more long-term now may have some other sort of eye disease like keratoconus, or some sort of other irregularity that we might be a little bit more concerned about. And there's some conjecture around whether you should be fitting someone with keratoconus with Ortho-K or not. I tend to avoid it until we know more about it. Perhaps with some cross-linking, some co-management with an eye specialist who specialises in cross-linking, maybe that's something that will emerge. But at this stage, that's part of a careful check, is making sure that the cornea is intact, making sure there's no dystrophy there that's going to preclude them or put them at a higher risk of an infection.